Just like we saw with obesity and insulin resistance and type 2 diabetes, when it comes to obesity and cardiovascular disease, the only true statement is that we don't fully know how they are related, the exact mechanism that links these two diseases. That said, we know they are linked. A meta-analysis of 57 prospective epidemiological studies showed that each about 5-unit increase in BMI above 25% increased mortality risk by 30%, but CVD mortality risk by 40%. Now how? And that's what we keep getting back to. How are these related? So there does seem to be some factors that directly link obesity and cardiovascular disease, including the pro-inflammatory state that is occurring in obesity, which we keep talking about. And we also believe that there are some indirect pathways from obesity to cardiovascular disease. So for instance, because it promotes insulin resistance and diabetes, type 2 diabetes is one of the main risk factors for cardiovascular disease. Okay, so more of like an indirect pathway to CVD through type 2 diabetes. But high blood pressure, another big risk factor for cardiovascular disease, as is dysregulated lipids in the blood. Those are three main risk factors for cardiovascular disease, and obesity promotes all of them. Okay, so again, it's hard to tease out what's the exact pathway, and quite honestly, there's multiple pathways from obesity to cardiovascular disease, both morbidity and mortality. So this slide is a summary of some of the adverse effects that obesity is associated with that help link it to cardiovascular disease. So for instance, like we talked about, an increase in insulin resistance, that's a big pathway towards cardiovascular disease. Obesity also increases high blood pressure because stroke volume goes up, and also because we see an increase in overall cardiac output, but also in peripheral resistance too. And we also definitely see dysregulated blood lipids too. Okay, we also see remodeling and big changes in the cardiac muscle structure as well. But really, there is a number of different things that link obesity, that we see higher risk of in obesity, that link it to cardiovascular disease. So we're just going to focus on some of these, but I wanted to give you the slide to give you some of the other things to think about and rabbit holes that you can go down when you're trying to understand what links obesity and cardiovascular disease. Okay, so we know, or you probably know by fourth year in BPK about atherosclerosis, and you probably also know that LDL, higher levels of this, what we call bad cholesterol, especially small particle bad cholesterol and oxidized LDL, are associated with a higher risk of atherosclerosis. And for my first year students, I like to draw atherosclerosis. If this is a blood vessel, I like to draw it kind of like this, right? Where our blood vessel is narrowed and there's less room. Our lumen is shrunk. There's less room for blood to flow, and a higher risk, should have changed colors here, but there's a higher risk that a blood clot can form in that narrowed vessel, promoting lack of blood flow, and if it happens in the heart, that can promote a heart attack, and if that happens in the brain, that can promote a stroke. But atherosclerosis, things that increase the risk for that are high blood pressure, are dysregulated blood lipids, is diabetes as well. So there's a lot of links between obesity and atherosclerosis, and that's just one form of cardiovascular disease. Okay. So like I kind of already went over these, but these are some other things linking obesity and atherosclerosis. We see higher C-reactive protein in obesity and in cardiovascular disease, and that might be, like, again, one of the linking factors. Higher amounts of this pro-inflammatory marker are often seen in cases of higher oxidative stress and endothelial dysfunction, which again, we know by now can promote atherosclerosis. Okay, the pro-inflammatory adipokines that are being secreted by adipose tissue might also increase the amount of arterial plaque formation due to the higher levels of adhesion that we see on the endothelial cells, promoting again more of that narrowing, that build up that we see in atherosclerosis. Okay, and of course we know that macrophages changes in obesity. Okay, and so do things like T cells. So macrophages change in obesity more at the local level. Okay, but we also saw, remember with obesity, and I didn't really talk too much about this, but we also saw a higher activation of T cells. And T cell activation might promote the macrophage recruitment that is part of that atherosclerosis progression. Remember, macrophages, as they consume LDL, they can become foam cells, and that buildup of foam cells contributes to that fatty streak that is associated with the narrowing of that artery. Okay. Insulin levels, which we see are higher in obesity, might promote the proliferation of smooth muscle cells. And again, if you remember atherosclerosis, smooth muscle cells, these can cover up the plaque at some point. Those smooth muscle cells move to the periphery of that fatty buildup, causing it to kind of get stuck in there. Okay. And leptin may stimulate that progression of the macrophages into foam cells. And again, these are all just different parts of the atherosclerosis pathway that are increased, their chances are increased in obesity. Okay, so like we said, lots of dyslipidemia in obesity. In particular, we see high VLDL, an increase in small, dense LDL, and that good cholesterol, I don't like that name, but anyways, that good cholesterol, the high-density lipoprotein, that which clears cholesterol from the blood, returning it to the liver, and that's associated with a better or lower chance of developing atherosclerosis, that's decreased in obesity. Okay? So it's not one thing that links obesity and atherosclerosis. The orchestrated effects of hyperinsulinemia, hyperglycemia, high blood sugar, fatty acids, and all these pro-inflammatory adipokines and other cytokines as well promote that stress on the vascular wall, increase inflammation, promote dysfunction of our endothelial cells, and all of that promotes atherosclerosis development. And if you remember back from when we first talked about adipokines, we also talked about plasminogen activator inhibitor 1. And remember that that is elevated in obesity. And remember that that is something that promotes the formation, or reduces the dissolution, I should say, of thrombi, those blood clots that can, again, like I said, get stuck in a narrowed artery, promoting, if it happens in the heart, a heart attack, and if it happens in the brain, a stroke. Okay, so there's a lot of things linking obesity and cardiovascular disease. In addition to the atherosclerosis promoting effects of obesity, there also is a strong correlation between obesity and dysfunction of the heart muscle. Part of the reason is that the heart has to work a lot harder to supply blood to the now more blood vessels that exist in individuals with obesity, because they have a larger frame altogether. Fat tissue may also deposit between muscle fibers in the heart, decoupling them electrically, again promoting dysfunction of that heart muscle. And also we know that visceral adiposity in particular secretes a lot of adipokines that are dysregulated in obesity, but we also see a lot more epicardial fat in individuals with obesity. And we believe that that epicardial fat as well, or we know it can also secrete adipokines, which can also potentially damage the heart muscle, and in particular promoting left ventricular hypertrophy. Okay, So, like I mentioned, these are some of the effects on the heart muscle that we see in obesity compared to a normal heart, or one that's not in obesity. In a heart of someone with obesity, it's usually larger overall, and a lot of that has to do with the myocardium getting so much larger. We also see enlarged atria and ventricles as well.
So this all brings us to an interesting conversation around something known as the obesity paradox. And although we know that obesity significantly increases the risk of heart failure, this has been shown by Framingham data decades ago, that each unit increase in BMI was associated with a 5% in men and 7% in women increased risk of heart failure. So the relationship between obesity and heart failure is well established. But what's interesting is that individuals with obesity, specifically like the BMI 30 to 35 obesity, if they have heart failure, compared to individuals that don't have obesity who also have heart failure. So if we have a population with heart failure and we divide them into those with obesity and those without obesity, those that have obesity actually have better outcomes, actually tend to live longer and have less complications compared to people with heart failure that are of what we might call normal BMI. So before we look at a slide that kind of shows this, I just want to differentiate between something called heart failure with reduced or preserved ejection fraction. Approximately half of people with heart failure and obesity have something called reduced left ventricular ejection fraction, which is also known as systolic dysfunction. And about the other half of people with obesity have preserved left ventricular ejection fraction, which is something called diastolic dysfunction. But in both of these cases, so this is with preserved ejection fraction and this is with reduced ejection fraction. In both of these situations, when we look at years following diagnosis, those with obesity class 1, so that's the yellow dots here, have, compared to those with higher levels of obesity and compared to normal weight individuals, those with a BMI of less than 22.5 or between 22.5 and 25, individuals with obesity with heart failure with reduced ejection fraction actually fare better when it comes to mortality risk compared to those of a normal BMI. And the same thing is mostly evidenced with preserved ejection fraction again. Again, those with class 1 obesity, you see that line here, kind of above that red line that I just made, they actually have a reduced mortality risk compared to those with a lower BMI. And this kind of doesn't make a lot of sense. Like, what is it exactly? Why would obesity provide some sort of protection towards the complications associated with heart failure? And quite honestly, we don't totally understand. One of the possible explanations that we often see is that it's somehow related to muscle mass. We're going to talk about sarcopenic obesity later on in the semester, and sarcopenia in general later on in the semester, where we have this reduced muscle mass and reduced lean mass, which we see in some individuals with obesity and some people without obesity as well. But what's interesting is that if an individual with obesity is still fairly active, even just kind of in daily activities, think about it. Someone, let's say, that's 250 pounds or 300 pounds or larger, they're carrying around an extra 50, 100 plus pounds on their body every day. So their muscles are often going to be a lot stronger. And perhaps that musculoskeletal muscle retention and hypertrophy in a lot of cases is associated with kind of a better outcome, better cardiovascular fitness, and also better overall outcome when it comes to having heart failure.
Okay, so or sarcopenic obesity, that's going to be a problem where there is a lot more fat mass compared to lean mass. But in non-sarcopenic obesity, so when individuals retain that skeletal muscle mass, that potentially has a protective effect. And I thought this was worth mentioning because I know a lot of you guys are working with individuals with obesity, perhaps in a fitness setting. And if that's the case, you know, a lot of people with obesity or who have a higher weight are looking towards working out for, you know, weight loss, and that's, you know, that's okay too. But there's another benefit to working out, and that is or having more skeletal muscle, and that is potentially a lower risk of disease, lower risk of sarcopenia, and lower risk of disease, even if someone still has obesity as well. Okay, so we don't fully, like I said, know the mechanisms here, but this comes up a lot in the obesity literature, and this obesity paradox is worth mentioning. It's also seen a bit in certain forms of cancer, where individuals with obesity sometimes have a better prognosis, but again, the full mechanisms are hard to fully understand. Okay, so this slide kind of gives some potential reasons or some kind of things that might promote that improved outcome in heart failure, and I want you guys to be able to kind of tell me what's going on this slide. So part of your reading this week is this paper in particular. But individuals with more lean mass compared to those with more fat mass, they might actually have more protective changes, including an improvement in cardiorespiratory fitness and an improvement in cardiac output that has basically an improved effect on the functionality of the heart. And this might predict a better outcome in those that have both obesity and heart failure. Okay, so interesting relationship. Okay, so this again brings us back to that conversation about metabolically healthy obese. So we looked at that when we talked about inflammation and obesity, and it may or may not go beyond just the inflammation or reduced inflammation that we see in some individuals with obesity compared to other individuals with obesity. It could also be that individuals that have more of this metabolically healthy profile that also have obesity, they might have more lean muscle mass. They, like we said, have a better kind of adipokine secretion pattern, which has decreased inflammation. But there might be a number of factors that's promoting this more metabolically healthy profile that goes beyond just the change in adipokine secretion. So just again, giving some more emphasis on how important it is to look beyond BMI when we're talking and dealing with individuals with obesity, because not everyone with obesity has necessarily a metabolically unhealthy profile. And that's why the ejection staging system is often preferred in certain clinical settings, because it helps us kind of group people, not just by BMI, but how their adiposity is affecting both their physical and in some cases mental health as well.